This is plenary session 4 on decoding digital transformations in healthcare. Please join me in welcoming our panelists to the dais. The session will be moderated by Dr. Rana Mehta, Senior Partner and Lead Healthcare at PwC. We have with us Mr. Pankaj Sahani, Chief Executive Officer, Medanta Medicity, Dr. Alexander Kuruvilla, Chief Healthcare Strategy Officer at Practo, Mr. Devesh Verma, Chief Technology and Innovations Officer, Community Science Alliance, Social Alpha, and Dr. Vaibhav Kapoor, co-founder, Preston Care. We will also be joined by Mr. Naveen Kumar, Special Secretary at the Ministry of Health and Family Welfare, Government of Andhra Pradesh. I will request our panelists to please join us on the dais.
Thank you. And again, I think it's a pleasure to be here. And I think one of the most important areas in we've spoken a lot about digital. I think how we are decoding it. You know, as I was coming here, I said, while we had a lot of things which went wrong in the pandemic, I think the two silver linings was the blue skies. And today it's gray in Delhi again. And I think the second silver lining was it made digital happen. It wasn't the CFO, it wasn't the CIO, it wasn't anyone else. It's COVID which made us all digital. So I think the second one, obviously, is going to last for a much longer period of time. You know, people who hadn't heard of telemedicine suddenly came online. I think a lot has happened in the last 1 year, and the whole idea is to decode it, give it a reality check. I think two components have become very, very important. I think in India, and people say, what's the Indian model of healthcare? I don't think we have a model. We have hundreds of models, and we've taken something from everyone. But I think there's three axes to care. You have a geographical axis to care, but still, 70% of our infrastructure is just in the major cities. The second is a financial, and I think the government's predominantly moved away from a provider to becoming a payer. In 75 years, it did provide care. The next 75, as it becomes a payer, it really needs to look at it. And I think the third point is actually, which is going to be the Indian model of healthcare, is a technological access to care. So I think those components of how do you bring in technology that it impacts your life 24/7. You can access healthcare 24/7. And I think that's not only a model we'll build for ourselves, but that's a model we probably will also build for the world. So I'll start with you, Naveen. I think, are we putting those building blocks in place today? Say that, if we came to this conference 10 years ago, they said, we took the right decision now.
Thank you. Yeah, I had to run for a flight, so I had to do this panel quickly. So, yeah, he talked about, I'm going to talk about the growth story of AP. We are 35 million ABA IDs, which is health IDs, and about 15 million health records. What is these things going to do? So in fact, in the last panel, I talked about collaborate to disrupt. This is the biggest knowledge disruption which would happen. All these records which are sitting there is meaningless, right? It's not just one data which is sitting there. It's also kind of information. When you talk about the hierarchy of the information theory or the theory of information, you have data, you have information, above it is knowledge, and then the wisdom. So you build that pyramid. This is exactly what is doing. The ABDM is creating that platform to do this pyramid. And that is, I think we have Preston Care here, we have AK Care. In fact, when we started doing this entire journey on ABDM, we were talking to all the private players first. In fact, then we spoke to AK Care. He was able to tell us, why would a doctor would use an application like AK Care? He was telling this because the doctor would want to know where his patients are coming from. So he talked about geography, right? He wants to know the geography of the patients, so that he can set up a clinic there. That is a win-win for the doctor. And what would government would do, or how would government benefit us? We'll also know which are the cases would come. For example, if you ask me what kind of cancer happens, or how many numbers of cancer are there in the state of Andhra Pradesh, I'll tell you an approximate number. Maybe it's 50,000, 60,000, or 70,000. But I'm very sure it's somewhere between 60,000 to 70,000. I can't pinpoint and tell you. For which, I think yesterday we also talked about documentation. That is the beginning of our journey. And when we do this one, we'll be able to pinpoint which are the kinds of cancer which would come and set up government facilities or collaborate with private to set up facilities there. When we talk about digital technology, we all think it's not whatever the bigger, it's not digital which is important, it's the healthcare which is important, and digital is the enabler there. So that is the strong point here. What does it also add to is, we also talked about the medical innovation. Why do you think that there is not much medical research which is not happening in the country? It is because of lack of EMRs. Whichever institution has a very strong EMR is able to put strong, research. And in fact, I remember seeing this VHS in Chennai, which is also a lead in HIV/AIDS control in the country. They are able to do it. They are able to publish good research paper in the standards, Western standards. I'm talking about, there is this Professor Kumarasamy who is able to put good research papers in the international arena from India because they are able to produce good research papers. We also talk about the indigenized protocols. What we all follow in the medical community is the Western protocols. Do we have certain medicines? I think the last speaker in the panel spoke about the term he was missing was precision medicine. Me and you are not same. The medicines will not work the same. And we also have this AMR which is coming. So these are recognition. How do you do it? The scale at which we want to respond, the public health care could respond to whatever is happening, be it COVID, or be it cancer, be it diabetes, or be it AMR, which is the biggest thing which is looming. The only way you would respond to it is by putting a strong digital healthcare or backbone which would provide information. It's an information system also, and also would enable us to make wise decisions to set up a system to, I think that's the missing gap. I think when you put it, you are effectively, in fact, I can also do an Indigo crew management if I have a good, strong AI-based or a digital system there, right? So I can also put teams to, negate or this thing. So I think that digital technology would be that enabler which would provide for and better the public healthcare system. I think 10 years from now, I keep telling this thing, the kid who is born in Andhra Pradesh would have all its record in the digital health system. When he goes to an hospital 20 years or 15 years from now, all the information would be available where we can think of, I think the ABDM which we are doing in this country could provide that scope for precision medicine, I think, and also believe strong medical innovation and medical research. I think that's the future of the side effects when we talk. In fact, I have a doctor in Guntur Cancer Hospital who is already started putting this research. Post-COVID, we talk about people having palpitations, we have cardiovascular diseases. There is no record. I go generally to talk to my doctors on an inspection. How many cardiac cases you use? They don't have record, but they generally, from a mind, what you call common sense, they will tell you, so there's a lot of cardio cases which are coming. What we see is, we always publish things which have already died its relevance. I think the relevance is over, right? So what we are looking at is research in action. When you are doing research, that should also be in action. So I would probably call this word research in action as the future, and this digital technology would enable us to do it.
No, excellent. And I think we have all the building blocks. And like you said, research in action. A best example is the COVID vaccine. A vaccine takes 10 years. But this time you had the regulatory approvals, you had the data, you had AI, you had technology. And instead of 10 years, we got it in 10 months. So I think, really very encouraging to see that we have this. Because I think for us, the biggest thing in India is accessibility is limited by affordability. But the money we have, we also don't spend it properly. Because a patient who moves from a village to a small city to a large city keeps getting the test done again and again, which is not only a waste to him, but a waste for the country. No, thank you on that. Pankaj, I'll move to you next. I think when we look at decoding digital, one of the things is that, while I think it got incubated a lot during the COVID time, there is now a reality check. Digital works for a lot of places. Digital maybe at some places needs to be there, but is not integral. So as being part of one of the largest providers in India, where do you think is the right place for digital healthcare?
Thanks, Rana. So I think couple of thoughts, right? One is that the very quick answer to this is that digital will exist everywhere, not only in healthcare, but frankly in all parts of life. So, I remember this many years ago, people used to, go to companies and they would ask, what's your mobile strategy? And I remember maybe, once the mobile revolution hit India, we started talking about the fact that there is nothing called a mobile strategy because every company has to have mobile as part of the core. I think similarly today, there is nothing called a digital healthcare strategy. Digital is inherent in the way in which you do work. So I run a group of hospitals. When you talk to hospitals, nobody comes and asks me, what is your front office strategy? It's just part of the way you do work. Nobody asks me, what's your nursing strategy? It's part of the way you do work. I think digital is also now part of the way you do work. So I think we should stop actually having separate panels on digital. We should think about digital as integral to how you operate. No, but we don't have special panels on, how do you work in the operating room. So this is, I think, my short answer to this. However, I think the important reality check is that digital is not a magic wand. So, Rana, you mentioned in your opening comments that, COVID showed us digital. Actually, digital was there all along. What COVID did is that doctors actually realized that, patients are not coming to OPD. So all the people who thought that why should I bother with digital because I have a long line of patients sitting outside my OPD, they suddenly started to panic. And they said that if I don't get into digital, I'll not have any business. And so what I actually say is that digital was there long ago. Doctors realized that it is there. Patients were ready much before because they have been using digital technology. So what COVID did was show us that it works and you have no choice. But again, we must realize that digital is not healthcare. I think Naveen mentioned it. Digital is an enabler to healthcare. Fundamentally, healthcare requires two things. It requires a patient who has to receive the healthcare, and it requires a caregiver, that in most cases is a doctor, but not always so, that has to deliver the healthcare. And so there is no telemedicine solution that will solve the patient's problem. So if I have a heart attack and I get on, touch with my doctor, and the doctor says, listen, you're having a heart attack, rush to a hospital, how has telemedicine helped me? Right? So I think that the important point in which we need to realize is that there is a sacred bond of trust between a care provider and a patient. And what we as institutions need to do is figure out how do we build around this sacred bond. And unfortunately, what I see is too many people trying to bypass this sacred bond. And the main reason you're bypassing this sacred bond is because, you say that dealing with doctors is painful. There are not enough doctors in the ecosystem. So what you're trying to do is you're trying to bypass this bond. And, Devesh and I were chatting before this panel started, and I mentioned this to him. I say this to every single startup that I meet in the health tech space. I said, look, 3 kids from IIT with a doctor on the advisory board working out of a basement in Bangalore is not healthcare. If you want to understand healthcare, go and sit in a primary care clinic and understand what happens when a doctor and patient speak to each other. Come and sit in one of our hospitals and understand why a doctor behaves in a certain way as opposed to what you think should happen because that's how Zomato does it. And this, I think, is broken in the way in which we are actually trying to digitize.
Exactly. And I think if we put that together, rather than excluding anyone from the ecosystem, then we'll sort of set it up for success. Alex, I'll come to you next. I mean, traditionally, companies in healthcare have been what's called the pipeline model. So you have a water pipeline. You build the services on one side, it gets consumed on the other side. Just to make the analogy better, the valve is a regulator, right? But when mobility stopped, practically most of these services, as Pankaj said, the doctors panicked. Now, obviously, Practo's been built on a very different model, like a platform. So what have been some of the learnings, and how do you see this larger platform play integrate with all the other players in the ecosystem?
Good afternoon, everyone, and thank you, CII, once more to create a forum like this to interact with everyone. Yeah, I wanted to tell Mr. Naveen Kumar before he left that he's now sitting next to another person who's in the transitory India. I'm hoping to be still called the New Age India, but I'm also one of that one who's in transition, right? I spent 20 years in the brick and mortar corporate hospitals, working as a CEO of a few hospitals, and every now and then there'll be people who come up and say, why don't we start a service post-orthopedics? Instead of them coming back with a plaster on a stretcher, why don't we reach out to them? Go there and get the dressing done and things like that. But the pace at which each of these innovations happened in the yesteryears were comparatively slow. The very fact that we have 1.4 billion citizens, Indians, with 1.14 billion people using phones, mobile phones, is primarily, not entirely, but primarily for convenience. Right? Today, everything is at your hands. It's not purely for communication, but it's also for communication. I mean, for convenience. You can book an air ticket, you can do your banking services, you can do everything. Healthcare, has always been the last to be adopted into this because it's comparatively very complex. And as Mr. Pankaj said, I mean, the final element is between, the treatment happens between the doctor and the patient. But yes, IT can support this a lot. At Practo, I still remember as a doctor, some of the time that I spent was to answer questions. People reach out. All doctors, I'm sure, went through this. Who's a good dermatologist in town? Who's a good dermatologist in Indiranagar? Who's a good dermatologist in Connaught Place? One of the first things that we did at Practo was discovery. You're able to find a specialist of your requirement in your hyper-local area with a kind of experience and the kind of requirement that you have. The next thing that we did was to create appointments, and the relevance of it came very clearly during COVID time. Even though COVID is not there that much in existence, OPD areas still spread infections. It may not be as fatal, but you pass on infections, right? You go sit in a very compact area and take that infection back home to everybody else. So can we have an appointment system where you don't have crowded places? There were times when doctors felt that they were doing well when they had a crowded OPD, and that, to some extent, a display of that too, right? We went into pharma delivery, we went into diagnostics. We actually would like to be a company, as mentioned in this, a holistic digital health company. So we are into pharma delivery, we are into point-of-care diagnostics, where samples are collected. We recently got into chronic care, and we are very, very encouraged with the results, with the remission results that we have. We got into secondary care space, and in secondary care, I think Dr. Anupam Sibal is somewhere around here, and Dr. Rana, we come from the older generation of, I don't know how many of us, 500,000, 1,500 of us, who work together to bring tertiary corporate care with the kind of quality that it has today that actually encourages medical tourism. But out of 30 million surgeries that happen in a year, almost 80 to 85% of them is secondary care. Now, secondary care out there, if you start driving that into higher centers, either the cost of premium is going to go, for the insurance is going to go up, or you're not going to get a certain portion of the population into it, or the prices is going to go up. So can we bring in a branding into the secondary care? And Dr. Vaibhav is here with me, and there are a few of us. We are working within this space where we identify hospitals based on the infrastructure, the equipment, the processes that they have for the kind of procedures, secondary procedures, that it can perform. We do credentialing and privileging of doctors to do those procedures, and then we have data mining for average length of stay, readmission within 48 hours, antibiotic policies, and multiple other things to give a feedback back to the hospital and to the doctors to see how all of this can be improved on. can we now bring in the secondary care into an area where the tertiary care is today over a period of time is the other thing that we are working towards. So the final thing I would like to emphasize on, we as caregivers in the past did everything we could the moment the patient walked into that door, into that infrastructure till they were discharged. A lot of work now is happening digitally, pre-hospitalization, post-hospitalization, and continuous care, like IoTs. And it's amazing with the 8 billion population around the globe, today there's 35 billion IoTs being used, which includes your computers and your mobiles. And it's expected to reach 50 billion IoTs in the next 5 years. So you're going to get humongous data, and one of the things that Dr. Rana told me before the session was, please also highlight the obstacles. All this data is available out there. How does it get structured? And therefore, because it's structured, easier analyzed, and how does it get interoperable will be the key. But it was great to hear the previous session on people talking about the changes that's happening in this country. And I really do hope everything that we look forward to happen in this country do happen.
No, thank you. And I think a lot of learnings of, how can we really make it better. Webber, I'll go to you next. And I think, any healthcare conference, I think it always begins with there's a lack of infrastructure in India. There's a lack of doctors. There's a lack of equipment. There's a lack of nurses. I don't know if we have anything which is appropriate. But the ground reality is that if you move out, very few hospitals, even in India, are 50% utilized. The occupancies are low. Utilization is a big, and you've still not come across a doctor, no matter how busy he is, saying, I can't see more patients. So obviously, I think there is a mismatch. At one stage, we're saying, let's build more infrastructure, let's open more medical colleges, but utilization still remains a problem. So in your model, how do you address this? And what do you think are some of the challenges as you go ahead?
Hi, everyone. So I'm a surgeon. Basically, I have, of course, been part of Medanta for 1.5 years before I ventured out into my private practice. So a lot of learnings from there as well. I was in the GI surgery department there. So I think, you rightly pointed out, the first dilemma is, we always talk in every conference we go that India needs more hospitals. The truth also is, beyond the top 10 branded hospitals in India, all other hospitals work at a 30–40% utilization or even lower. Similarly, we say, India needs more and more doctors, but every doctor you talk to, he will say, "Mere ko zyada patient chahiye apni OPD mein." Right? They are open to have more patients, coming to there, and they're willing to see them. So I think these were the two things which sort of, when I was sort of into my government practice and private practice, I could clearly understand. And then the third important part was, we could see over last 7–8 years, there has been a tectonic shift in patient expectations or customer expectations. And when I talk about customer expectations, it's not about the rich or the super rich. It's about everyone, right? Even the lower middle, the middle, and everyone. So today, for example, if you have to sort of, if you don't have groceries at home, you'll probably use a Zepto or a Blinkit to order it, immediately. You'll probably have a Uber, Ola, to commute. And then you'll probably, sort of buy something from an Amazon or a Flipkart. The idea is it's for everyone. Even the household maids, use these apps and look at convenience. So what we could clearly see was that people, who come in healthcare also require convenience. So these were the three basic thoughts when we started Pristine, that there is enough existing hospital capacity, especially in the mid-size segment. There are enough doctors who need more and more patients. And third, service excellence, is limited to currently a few hospitals only. It should be generic for everyone. So that's how when we started Pristine, and Pristine is into the secondary care surgeries. So what we said was that surgery is just not a 2-hour procedure. The doctor would take probably a 2-hour surgery 1 day in the hospital and that's it. But if any one of you or your family member has ever undergone a surgery, you would realize it starts from the first consultation and then probably to multiple consultation and then tests and then admission, insurance clearances, and then the surgery, and probably then couple of or 3 or 4 follow-ups. So it's an entire journey of almost 30-40 days, not just for the patient, but family members are equally involved, right? So we said, okay, let us break this journey into 20 or 30 different parts. So when we started Pristine, we broke that journey into 20-30 different parts, and we solved for each part. So that's how we said, okay, we'll bring convenience to every step. So like you said, how did we do that? So when we went to these mid-sized hospitals, we identified, one, they are not updated with the latest protocols. Probably their OT staff or their nursing staff or in the wards, they're not updated with the latest protocols which they have to follow. So we at Pristine first set up a quality team inside. We now have this team more than 100 plus which are there in different cities, and we said, okay, these quality consultants will go to these hospitals, lay down protocols. They'll do a swab culture in the operation theater, they'll do a sign-in, sign-out technique in the operation theater, they'll probably train their nursing staff into what is code blue, what is code violet, what are the latest measures, what do you do if a patient has a fall, what do you do if a patient has an allergy, are there emergency trays, everything in place or not. So that was the first thing which we did with the mid-size hospitals. And second, we realized probably they don't have enough financial might to buy all the latest equipments. So Pristine then invested into these latest equipments, be it holmium laser for kidney stone surgeries, be it lasers in proctology, be it coagulators or microdebriders for ENT procedures, be it any other latest equipment which is needed for these secondary surgeries. So we bought ourselves and we then placed them in these hospitals. So now practically all these hospitals were equipped with latest protocols and they were equipped with the most advanced technology. Hence, patient trust on these hospitals increased. Second, for doctors, majority of the doctors at Pristine, they work full-time with us, and, like I said, at Medanta, I learned this thing, when you have doctors full-time, doctors can follow your processes very well. For example, in my GI surgery department, everybody, had to follow similar protocol in every surgery. So now since at Pristine, we have all the doctors full-time, they follow entire process. So whether it is Chandigarh or it is Chennai, the process remains the same. So you're able to standardize how the doctor will behave either in the OPD or in the IPD or post-op. So that standardization has really helped us, grow really fast. And the third thing was on the patient side, like I said. So we divided the patient journey into 20-30 different parts, and we sort of, tried to improve every, journey at every step, whether it is a virtual care coordinator, which is given to a patient. Any complaint, anytime patient has a problem inside the OPD or during his test or inside the hospital, he can call this guy, and of course with the use of technology and Salesforce and everything, we can just, ensure that the complaint is immediately met. A small example, what we found was a lot of patients complained that, admission might take 30, 40, 50 minutes, just going to your room once you reach the hospital. If there are 5-7 patients ahead of you, the admission time almost is 40, 45, 50 minutes. So what we said, what is happening in our counter industries? So for example, if you look at airline, if you have to travel tomorrow morning, and it's just a day journey for you, you would probably take out your boarding pass 1 day prior so that you can just skip that queue, right? Similarly, what we did through our apps and the hospital app, we would send patient information 1 day before to the hospital. Hospital will receive all the documents and hospital will generate a ticket for, patient. So next day, a Pristine patient walks into a hospital. Even if there are 7-8 patients in line before, the admission time was reduced to less than 15 minutes. It's a very simple thing which we just, so, airlines have done it successfully and we should implement it here. So, and there are many more examples like these where we just try to sort of, make small changes everywhere, which could have, a very, very large effect on the convenience or the care for the patient. So I think that has been one of our reasons that we've been able to grow, at a rapid pace and at a decent scale, at present over the last 4 years.
Thank you. I think very good insights and, keeping the patient at the center of all your activities. I'll go next to Devesh. And Devesh, so you're slightly different on the panel because you predominantly come from a technology side, and which gives you a different lens to look at it. Sometimes, you're from the same industry, you can't see the solution, right? I think while we've spoken a lot about it, on a population health, how do you see this digital really having an impact? Because, next year, guess what? We're going to be the largest country in the world from a population perspective.
Thank you. So I come from technology, but come mostly from a public health tech part of it. I've spent a good amount of time trying to solve complex problems in primary care using technology. But I'll come to technology in a bit. I belong to an organization called Social Alpha, which is a not-for-profit organization. And Social Alpha is, as an organization, a multi-stage innovation curation and venture development organization for science and technology-based startup who are trying to solve complex, hard, economical, social, and environmental problems through the power of entrepreneurship and innovation. The reason I wanted to go into this definition is because even in the previous session, we touched upon innovation. Naveen spoke about innovation. We spoke about disruption also. So before I go into at a population level and solve those issues, or at least try to solve those issues with the technology-enabled systems, I want to kind of go back to the first principles and talk about when we say disruption or a transformation, we have to also take a step back and understand how easy it is. Transformation is a good term to talk about, right? But we have to also look at those incremental, non-linear transitions that happen right from ground up, which then result into some large-scale transformation, which we talk about, may be enabled by digital. May not be. It could be a process innovation which results into something very disruptive, which helps a primary healthcare physician, which Pankaj touched upon, to deliver better care. Now, how do we solve for all of these? There are multiple different aspects to it. I heard Alexander talk about, and also Vaibhav talk about protocols. Picture a frontline health worker in a village in Sheikhpura in Bihar, or in Muzaffarpur in Bihar, or a Behraich in UP. Their ability to come up with a decision is not much. Their ability to take in a lot of data, write down information is really high. Now, can we look at these complex medical facts and distill them into novel, validated, easy to understand, lucid pathways and give it to them? My first line or my first mile connect with the citizen or a villager or a community will then change in terms of how these frontline health workers will look for what is happening and will then be equipped to send them to higher health facilities. It could be private facilities at secondary or tertiary care. But if we are trying to solve the problem at a village or a community level, we have to look at that. When we talk about transitions, or when I talk about transitions, we also have to understand innovation is something we spoke about. Now, it's not just technology innovation that we will have to look at. There are multiple layers of innovation that we will have to think about, which could be institutional, which could be social, which of course could be technological, and of course it has to be economic also. Because all of these things have to come together for people who are providing healthcare to start working towards ensuring quality delivery happens. And that is where the whole human agency comes into play. We can build, as technologists, I can go ahead and build multiple different systems which use fanciest of the words around AI and ML and whatnot. If it's not usable from a human-centered design perspective, then I have done injustice to a frontline health worker who cannot consume this and use it to provide the healthcare. So we have to switch the way we look at human-centered design or design thinking. I know design thinking was also which Naveen touched upon in the last session. It's very critical because typically what happens is we have a solution and we go find a problem. Ideally, we should go back and curate the problems to an extent which then could be percolated upwards, and then we can find those startups who are willing to solve those problems. Most of the innovative research, I know there was a question about how do we scale. Most of the innovations die in labs because there is no investment that happens in taking them to market. They fail. They die in the valley of death. So how do organizations like us and CII come in and then say, we will fund those innovations and we will look at solving those problems if we are talking about disruptions and transformations? Because transition may take me from one state to another state, transformation will change my shape. And we are talking about changing this holistically. That can be enabled by technology, but technology alone will not be able to solve it, because we always run into the human aspect. Now, when we go to the population level, simple things like early detection of high-risk pregnancies, or sending a fetal heart rate or heartbeat to a doctor using telemedicine, right? But then the human interaction also becomes very important. So how soon we can do that? What is the information that can be collected? We talked about continuum of care, but we should also start talking about continuum of information. But also very important is we have to talk about transition of care, where technology can come in and plug those gaps, where we then create a holistic, longitudinal, both horizontal and vertical, data set of health of a beneficiary, which can then be consumed at multiple different levels, and then the doctor or the health worker can take those meaningful decisions who are evidence-informed and contextually appropriate. I think those are the things which technology or us technologists can enable in helping the people who are actually trying to solve these problems. I can help a doctor, I can help a frontline health worker. I cannot solve for those. But unless I realistically understand where technology comes in, it becomes very difficult. So just in closing, Rana, to your question about population health, can that be solved by technology? I believe yes, it is. But we have to look at it holistically from a health systems point of view. Are we solving multiple layers of problem using technology? Then yes, it can be solved. I believe there will be a day when we will have information captured at a village level, go all the way up to the tertiary care hospitals. We will have all the relevant informations or encounters structured in such a way which gives us more insights and gives the doctor the ability to solve for those issues.
No, thank you. And I think it's really interesting and we can go on. But the human-centric design, I think obviously a lot of technology which gets made in healthcare actually never reaches the user, or the user doesn't want to do it. I think before I conclude, we did a session yesterday with 50 hospitals which were predominantly smaller in the tier 2 and 3 cities. There was a question, and Pankaj, I'd like you to answer this, maybe in 30 seconds. They said, if I'm a 100-bed hospital in Gwalior, what are the 3 things I should do in digital to set myself up for success?
It's a hard question to answer in 30 seconds. So I think the first and most important thing that I would do is actually understand, before you start any digital transformation or any of these other buzzwords, that we actually understand how does a doctor-patient interaction happen today. And I'll give you an example. I started out in this industry and I went to see another hospital, one of the bigger hospital groups, and they showed me that we have a telepresence room and this company will put this virtual presence software, etc., and this is all great and it's got 6 screens. And I went back to our hospital and I said, the doctor, by the time they leave their OPD chamber and make it to the elevator, there will be 35 people who will accost them on the way. They are never going to reach this telemedicine room. So what did we do? We got a TV. We put a little video camera on the TV. We got our biomedical guy to make a UPS machine, and we repurposed some casters and we made a mobile cart. And we said that the video conferencing setup will go into the doctor's chamber the way a patient walks into the doctor's chamber in the OPD. There is no telepresence room in any hospital in Medanta. But we do thousands of teleconsults every day, because we are taking the technology to the clinician, not taking the clinician to the technology. So my overall advice would be, before you digitize anything, please understand what ops are you actually doing, and by digitizing it, are you adding any value? If I take the big fat inpatient form that I have, in which I'm sure at least 50% information is repeated on one paper and then again repeated on another paper, and I digitize this whole thing, this is ridiculous. What I first should be doing is simplifying that, so that I actually only have to digitize 20% of it. But what we do, and we are experts actually in India in this form, I don't know when, if you have to fill 4 forms to get a birth certificate today, we have digitized it, you still have to fill 4 forms, but nobody asks this question, why do you need 4 forms? So my overall advice would be, don't digitize anything unless you fix first your ops and understand exactly what is it you're solving for.
No, thanks. I think that's the golden mantra. Like I said, we could continue, but very, very interesting, very good perspectives. I think I went, digital's becoming integral. So maybe, you know, going ahead, it'll be so integral to the delivery that we won't have a special session. And, you know, that will really show that it's come of age. I want to thank my panelists for all their insights, and I want to thank the audience for being so great. I'm sorry we couldn't take some questions. Thank you, and have a great evening.
Thank you, Dr. Rana. Thank you to all our panelists.